So let's talk about the classic features of some of these vessel types. So anterior circulation strokes are relatively uncommon. We believe that's the case because of just flow dynamics, just like right upper lobe pneumonia is more common than other pneumonia types because of the anatomy of where things tend to go. But they can occur, and this is where the homunculus comes into the equation. So if you remember, and I didn't put a picture up, you remember the guy that hangs over with the leg in the middle? So you have the leg, you have your sagittal, your hemispheres, your cerebral hemisphere, and a little guy hanging with the leg down in the middle. And then there's the face with the mouth at the top and the arm hanging off the side. You know what I'm talking about? Yes? You thought it never comes in useful, but it actually does. So the anterior cerebral artery is a slight misnomer because you think of it as perfusing the front of the brain, and it does, but mostly it actually perfuses the middle of the brain. So right along the sagittal section, midline. And that's where the leg hangs over. So what does an anterior circulation stroke cause? And it's anterior. Anterior is motor. Posterior is more parietal, sensory. So anterior central is the leg weakness. So, and I'm telling you this because while it's an uncommon kind of stroke, it can be the most difficult to diagnose, because here you have a patient coming into your surgery with acute onset of right leg weakness. Is stroke the first thing you think? Or are you thinking of a lumbar disc, but he doesn't have back pain? It came on really suddenly. Is it a spinal cord problem? You need to consider that it might be an anterior cerebral artery stroke. And that can often be the only symptom. Really big ACA strokes can cause, motivational things, which are really hard to pick up. You don't find them on examination, but some slowness in thought, abulia, amotivation, but often they're a bit delayed, and they're only visible in really large strokes. So the key really here is that leg more than arm and motor way more than sensory. You may not get any sensory symptoms with an anterior circulation stroke at all. Sometimes you can get a bit of dysphasia, but more commonly than not, it's just isolated leg weakness. Now, the middle cerebral arteries are most common large vessel strokes. I'm talking about strokes that are lodging in those three large vessels, ACA, MCA, or PCA. And the middle cerebral artery does the outside of the hemisphere. So in contrast to the ACA, it affects the face and the arm and sparing the leg. So that's the syndrome, or the MCA syndrome that we see clinically, is a facial droop with some arm weakness. And you see those TIA patients. Those are the patients we're really worried about. The patient has a facial droop and arm weakness, and then if it's the dominant hemisphere, what do we add? Dysphasia, right? So they cannot talk, and even if it's for a few minutes, that's the people who are coming back within a week with a large MCA stroke. Those are our highest priority patients for urgent assessment. So with the dominant hemisphere, you get dysphasia, face, arm, and arm more than leg. With the non-dominant hemisphere, they can be really difficult to diagnose because the patient is often completely unaware because it's affecting their awareness center. They get neglect or inattention. They're not aware, the anosognosia, they're not aware that they've just had a stroke. So they're getting this problem, and usually it's a partner dragging them in, saying something's not quite right with my wife or my husband, and they're just saying, why am I even here? And they're trying to walk, and they don't even really know they cannot walk. So they can be very delayed coming to medical attention, especially if it's only mild weakness, because they will downplay it, because they honestly are not aware they're having had the stroke. And then you get some apraxia problems as well. You may not be able to hold a pen, you might have the strength to do it, but you cannot quite write, you cannot hold a comb, those kinds of things. With both, you can get an hemianopia, where you get vision loss on one side or the other. And that's important to remember because not all visual loss that is a homonymous hemianopia comes from the occipital lobes. Do you know why that is? Yep, so it's already crossed, and the fibers have to get to the occipital lobe. So you're getting white matter tracks connecting the eye to the occipital lobe, they have to go through somewhere. It's not Bluetooth, right? So you have to connect them, and they have to pass through somewhere. And what's passing through? The parietal lobe. So it's and temporal lobes. So you can get with an MCA stroke, more so than an ACA stroke, you can get this. By definition, a full MCA stroke should have homonymous hemianopia, where you get vision loss on one side or the other, affecting both eyes. And you can, if it's only very high or low, you get a quadrantanopia. They're a bit harder to pick up, which is just a quarter of your vision. And middle cerebral arteries affect both motor and sensation, because it's right in that center where it's getting both parietal and frontal lobe, both motor and sensory cortex. So that's the anterior circulation. If you get an ICA stroke, internal cerebral artery stroke, you get all of it, because the internal cerebral artery supplies both the MCA and the ACA. Make sense? Now the posterior circulation, I'll have split here into the posterior cerebral artery and the basilar vertebral arteries, which are more proximal. So if you're in the posterior circulation artery, this is the stroke you get. Oh, by the way, this is an MCA stroke. See how large that thing is? It gives you a sense of why these people are really bad off and don't do very well. This is an occipital stroke with a bit of radiation into the temporal area, and that gives you predominantly the field loss, because that's what the occipital lobe does, the visual cortex. But it also gives you those subtle things of having memory problems and not being quite right, and something is a little bit different, and they may even either be a bit slower, or there's some cognitive problems that are difficult to pinpoint. These are very difficult to pick up, and they're often missed. And these are the people who come in with swerving across the center line because of driving. They've often been there for a while. Sometimes they've been there for a few days, and then they bleed into it, and it's actually the bleed that brings them to medical attention. So this patient would say something's not quite right with their vision. Sometimes they'd say blurred vision, because they're struggling to describe it. So if somebody has any visual complaint and you cannot quite put your head on it, especially if there's some other cognitive symptoms with it, make sure you check visual fields. This can be picked up on clinical bedside examination. Does not require an ophthalmologist. And then the basilar vertebral problem gives you that the various brainstem syndromes, and you can get you locked in, which doesn't usually present in your usual community setting. Somebody who cannot move at all except for the eyes. But you can get the staggering. This is the one sort of stroke that often presents with the staggering course, a basilar thrombosis with a bit of vertigo, a bit of ataxia. You get your diplopia, which immediately should get those red flags up, and you're exploring that as we discussed, and then maybe a bit of limb symptom. So these are the people we worry about of having a dissection or a basilar thrombus that is staggering and opening, closing, and then eventually gives you that locked-in stroke. And that's what we obviously want to avoid. So that's vascular stuff. And here I will send you the slides, I presume. Yeah. And I won't go through all that in detail, but there are small vessel syndromes as well. And this is where it's sort of useful to know a little bit about the thalamus and the brainstem and the basal ganglia. And we separate these 5 lacunar syndromes: pure hemisensory, hemimotor, mixed hemimotor sensory, clumsy hand dysarthria, hemiparesis, ataxia. If you find one of these syndromes, you can usually map them to a location. And if you find one of those syndromes, you feel like, oh yeah, this could be a lacunar stroke. And the imaging may be normal. We do CT scans when patients come acutely. They're almost always normal. We don't do MRI scans on these people. We localize the lesion clinically. If it fits a pattern, a vascular territory, we're confident that's what it is. Came on suddenly, has clumsy hand and some dysarthria. That's a stroke, a lacunar stroke. And the other feature of these hemi ones is because you're getting the fibers that are carrying the signal rather than you're getting the cortex, the whole thing is involved equally. So we talked about the homunculus, how you get more face and arm weakness in the MCA and leg weakness in the ACA. With a caudate stroke that causes hemimotor problems, it'll be evenly distributed throughout the body. So there's no gradient because it's a small area and you're taking out the entire motor tract. So basal ganglia can cause chorea, but it can also cause weakness. If you take out that whole nucleus because the fibers pass through there, it'll cause weakness. But it's evenly distributed. So I know I'm kind of overwhelming you. It'll get simpler now. Any questions about that? Yeah? Okay. Back to so this is all I need you to know about the brain. So if you know all that, you can do the neurologist's job of localizing the lesion. That's mostly what we do. Okay. Now, spinal cord. Spinal cord is just an extension of the brainstem without cranial nerves. So it's a very similar sort of thing. It's just tracks, up and down, no real neurons. I mean, there's the anterior horn cells, but that's kind of already at the level of the going into the peripheral nervous system. So it's primarily white matter that's moving up and down the back to connect your brain to your limbs. It carries sensory and motor fibers. There's crossed and uncrossed fibers, which are a little bit complicated, but you probably don't need to worry about it too much. We'll talk about it in a bit more detail in a minute, but mostly you need to just remember that some things are crossed and some everything crosses, but they're crossing at different levels. So you get slightly different patterns depending on where your lesion is. And it's still upper motor neuron, so we're still in the upper motor neuron system. So here, just briefly about the fibers. So you have these three main tracts. They're named based on where they come from and where they go. So the cortical spinal tract moves from the cortex to the spine. Let's move to this one. The spinothalamic tract goes from the spine to the thalamus. So what travels on the spinothalamic tract because it goes to the thalamus? Sensory fibers. It gives signal to the thalamus. It's an ascending tract. Cortical spinal is a descending tract, cortex to spine. The dorsal column is called dorsal column because it's a column-like structure in the back of the spine. Now, the cortical spinal tract, the thing is motor, like the dorsal column vibration position, spinothalamic pain, and temperature. And these two cross at the level of the brainstem, and this one crosses at the spinal level. So if you look at, here's the spinothalamic tract, so it's an ascending tract, so the signal comes up, it crosses right where it enters the spine, and then moves up on the contralateral side. The dorsal column tract goes and stays on the ipsilateral side up to the brainstem and then crosses over. And the cortical spinal tract, which is pink, moves down, crosses a little bit lower, and moves up on the other side. No, that's not right. This must still be brainstem. Oh, cervical cord, yeah. So let's look at the, sorry, I'm getting my... It's not a very good picture, is it? Sorry. But the bottom line is the cortical spinal tract and the dorsal column both cross at the level of the brainstem. The spinothalamic tract crosses at the level of the spine. So if you have a lesion in the thoracic spine, you'll get on the right side, you'll get right-sided right-sided vibration and motor loss, and left-sided pinprick loss. Okay, so you get the opposite side. All right, sorry, that was not my best moment of the day. Does that make sense? Hopefully. Just remember that some things cross different places. So you have your motor and your vibration sits on the same side and your temperature on the other side. And that's important when you do your localization. When you find somebody on examination, they complain of temperature loss on the other side, and it seems like it doesn't make any sense. You just need to be aware of that. So there are situations where that does make sense. Okay. Now, then we're moving down to nerve roots and plexi. Now we're in the lower motor neuron system. And you've got dorsal and ventral horns. The most common disease pathology there is a compressive disc lesion. Plexi, most people don't think about plexi much after they leave medical school. They're these things that run through the nerve bundles that run through your girdle, but also in the pelvis. So sometimes people are aware of the brachial plexi, but less aware of the pelvic plexi. So these nerve bundles exist in 4 places, and they can be affected by the same thing, and they tend to be inflammatory problems. Now, the brachial plexus lesions are more common than the pelvic plexus lesion. What's the thing that affects the pelvic plexus? There's one condition that diabetics get. Diabetic amyotrophy. Have you heard of that? It causes painful nerve damage, weakness more than numbness, but it can cause both. And it's basically infarcted nerve tissue with an inflammatory component in the pelvis, in the pelvic plexi. That is something that we see in diabetics. It's pretty rare, but that's one of the few pelvic plexus problems that we come across. In the shoulder, it's most commonly actually injury. So motorcyclists, or sport people, rugby players, if you have a sudden injury going backwards, and then they are the ones who get the winged scapula. That's a brachial plexus injury. And then you get these people who get this inflammatory problem where they get a lot of pain, quite sudden onset of severe pain. A day or two later, they get numbness, weakness in their arm, and it doesn't quite fit into a dermatomal pattern of a nerve root problem or a nerve pattern of an ulnar or median nerve or radial nerve. And you got to think plexus, because things get quite jumbled up in the plexus and you can get a variety of different syndromes. It's not really important to remember which one is the posterior branch and the anterior branch, but if you just know your nerve distributions of median, ulnar, and radial, and then you know your disc dermatomes, which most of you are really good at, judging from the referral letters we get, if it doesn't fit into either of those, you want to consider the plexus. Moving on to the nerve. So nerves look pretty much the same everywhere, but just to remind ourselves, we have an axon and then we have myelin. And we already talked about myelin in the brain. The white matter is mostly myelin. Myelin speeds things up. If myelin is not working properly, it slows things down. It's like insulation on wires. And it's really important when you talk about peripheral nerves. So peripheral nerves, again, we're now in the lower motor neuron system. We're all done with the upper motor neurons. And everything travels along nerves. And we separate nerves into different groups. And this is important from a localization perspective to diagnose your peripheral neuropathy. So peripheral neuropathy, which is a nerve problem, basically any nerve problem is a peripheral neuropathy because it's peripheral and it's involving a nerve that's bad, which is peripheral neuropathy. So peripheral neuropathy isn't equivalent to a polyneuropathy. Right? Median neuropathy is a peripheral neuropathy, so just from a terminology perspective, it just means a peripheral nerve is damaged. One or many doesn't contain that in that term. So peripheral neuropathy are split into large fiber, small fiber, sensory, motor, demyelinating, axonal, symmetric, and patchy. So if you can group them in all those, you have narrowed down your differential quite a bit. Now we'll talk a little bit more about the workup of neuropathy when we get to the cases, so I don't want to talk too much about that now. And in a way, you end up doing a bunch of bloods anyway. But it is useful. This is what we do when they come to the neurology clinic. So large and small fibers are relevant because toxic neuropathies tend to affect smaller fibers. That's your diabetics and your alcohol, some vitamin deficiencies. Sensory motor is relevant because especially some infection and autoimmune conditions tend to gravitate towards one nerve fiber or another. And sometimes they're not really technically neuropathies at all, they're ganglionopathies. So some things affect the nerve ganglion, like the sensory nerve ganglion. If it's a sensory nerve ganglion, you're not going to get a motor symptom because it's only affecting the sensory ganglion. Like Sjogren's syndrome, for example, tends to cause sensory ganglionopathy. But probably the most important is differentiating between demyelinating and axonal. And there's some overlap too. So most large fiber neuropathies tend to be more demyelinating, and small fibers don't actually have myelin, so they're all axonal by definition. So there's some overlap. But demyelinating and axonal is a really important differentiation. And because it helps you with differentiating things like Guillain-Barré syndrome, toxic neuropathies, inflammatory neuropathies. Most subacute inflammatory neuropathies like CIDP or these autoimmune conditions that anti-MAX, there's a bunch of rarer conditions I'll talk a little bit more about later, but they tend to be demyelinating neuropathies. And that's when we do our nerve conduction studies. Nerve conduction studies tell us if something is axonal or demyelinating. And axonal has loss of signal, dropped amplitude. Demyelinating, loss of myelin causes what? Slowing. So the nerve conduction is slowed. That's why we do nerve conduction studies, to separate those two, to identify if it's motor and sensory and whether it's demyelinating or axonal. What do you think carpal tunnel is? Is that an axonal or demyelinating problem? Some mumbling. So it starts with a demyelinating problem because it's pushing from the outside. It's a compressive problem. It's pushing, so you have your tendons that are overactive, they swell, they push on the median nerve as it goes through the carpal tunnel. So it's an external compression. It squishes the myelin. It takes a while to get to the axon because that's really deep embedded around this nice casing of the myelin. So on the initial nerve conduction studies, what happens is you have slowing of the median nerve. So you have a slowed conduction velocity or a delayed distal latency. Right? That's what you'll see in your mild carpal tunnel. As the pressure goes on and on and on, eventually the axon will be affected and you'll get axonal drop, which is a drop in amplitude. So that's how we grade carpal tunnel. Is it affecting sensation and motor? Is it affecting the axon or not? Make sense? Ish? Okay. Now the patchiness gives us an idea. So patchy would be if you have a mononeuritis, then you're thinking injury. Right, an ulnar neuropathy or a carpal tunnel are your two most common neuropathies you'll see in primary care, I would think. And certainly the most common ones we see in the EMG lab. So that's your mononeuritis. They tend to be demyelinating at first, and then as damage continues to become axonal. And then there are patchy ones that have more than one nerve, your mononeuritis multiplex. So those patients get little nerves picked off in a number of places. Anyone have any idea what the usual cause of that is? So you see that with vasculitis. So vasculitis is really a stroke, right? It's a inflammation of blood vessels until they block off, and you get loss of blood flow, and you get infarcted tissue. So peripheral vasculitis in the nervous system is they're strokes of multiple nerves. So they infarct one nerve, then another nerve, then another nerve, and it can happen in a random pattern around the body. And so the things we look for are often, like Wagner's granulomatosis, so these systemic vasculitides. Often they'll have renal problems as well. And then there's a few conditions that only cause nerve tissue problem. But so you want to look for vasculitis if it's in a non-symmetric patchy distribution in more than one nerve. And then, of course, you have your standard stocking glove distribution polyneuropathy that's ascending, starting in the legs, going up the feet, and by the time it gets to the thighs, usually, or the knees, it starts evolving the hands and it ascending. And that's usually your toxic neuropathies that affect the most brittle, sensitive, distal small fibers first and then ascend. Any questions about that? We'll talk more about individual diseases as part of the cases. So moving down the neuraxis, so we've done the brain stem, the spinal cord, the nerve roots, the plexi, the nerves. Now the nerve transmission needs to translate into motor action. And it does that via crossing the neuromuscular junction. We do not have a lot of neuromuscular junction diseases. The quintessential one is myasthenia gravis, which we talk a lot about but don't see very often. But we do have a number of cases in the Wellington area, as does every other place, and there will be somebody here who has a patient with myasthenia gravis. But it's not so much that it's useful to know that much about myasthenia gravis, because if you have a case, you can look it up. But it's a good reminder that there is that junction. And if you have somebody with pure motor weakness, you want to consider that in your differential. And that's really the key I want to make here, is that neuromuscular junction problems do not cause numbness, because it's a neuromuscular junction. There's no equivalent the other direction. It's just directly nerve fibers ascending up. And then you have your botulism, venins, neuromuscular blockade, obviously work in that during intubation. And there's differences between pre- and post-synaptic problems that I won't go into. But here's a picture. So here's your nerve ending called the podocyte. You can see why they're called podocyte, like little feet. So it's your nerve attaching to the muscle. There's your synaptic vesicles with your acetylcholine in it. They get released through calcium channels. Then the acetylcholine is ejected from the vesicles as it enters the space. This is the actual junction, and binds to receptors on the postsynaptic plate. And the acetylcholine binds to the receptors and triggers the action potential to then cause the contraction. Or rather, the calcium changes. The calcium changes in the muscle to trigger the action. The acetylcholine is then eaten up by the acetylcholine esterase and cycled back into the terminus. And in myasthenia gravis, you have an immunological problem where the receptors are attacked, so the acetylcholine cannot bind to the receptors and cannot trigger the motor function in the muscle by changing the membrane across to allow calcium to flow in and starting the action the muscle contraction to occur. And what we do is we give acetylcholine receptor acetylcholine esterase antagonists to keep the acetylcholine floating around for really long times in the neuromuscular junction to allow it to bind to the few receptors that remain. And that's how we treat myasthenia gravis. Yes? So the sweep up, the cleanup mechanism is delayed, allowing a longer period for the acetylcholine to bind to the receptors. Okay, that's the neuromuscular junction. And then we move to the muscle, which is the last. So the muscle is the final end organ of the nervous system as regards descending tracts. Lower motor neuron, it's only causing motor symptoms. And it sounds a little bit silly, but we do occasionally get referrals for somebody with numbness and weakness, query myopathy. It's not physically possible. The nervous system is highly logical. There's no sensation in a muscle. There's muscle fibers that the sensory endings that can move sensation up to the brain, but myopathy is a bad muscle and it causes weakness. So they tend to be bilaterally symmetric, usually proximal if you have a myopathy. Reflexes tend to be normal or down, and the most common conditions are your inflammatory polymyositis type conditions, dermatomyositis, toxic problems like statins, which we see a bit more commonly now. Alcohol is a cause, and steroids, which can be a bit of a problem because steroids can sometimes be a treatment for things like polymyositis. And then if you treat them and then they get weaker, you sometimes worry it's the steroids causing the problem. And sometimes the only way to tell that apart is by doing a muscle biopsy. There are dystrophies, of course, which are usually fairly straightforward to diagnose. And the main investigations we do for muscle disease is the muscle enzyme, which is CPK, and doing an EMG. EMG is a needle examination to examine the muscles, which is different than nerve conduction studies. They're done at the same time, and EMG can add to nerve conduction studies, but they're different things that we do, and I'll talk about that a little bit more later. So that is my summary of the neurological localization. So what I'm hoping that you've gotten out of this is that the system is really well organized. You've got everything motor-wise starting in the head and it's traveling down. sensory starts in the periphery and travels up. It passes through a number of connecting highways that need to be in place to connect these areas, and then there's a number of modulating nuclei that affect the perception of the sensation and the execution of the motor signal in the system. And if you have some understanding of where what lives, it helps you with localizing your lesion.